in the following minutes, I will share with you my experience with pediatric mycosis fungoides. We all know that mycosis fungoides actually affects adults, and most of the patients are above the age of 50 when they are diagnosed. And in the literature, it's written that actually pediatric MF, namely mycosis fungoides that is being diagnosed under the age of 18, is regarded as a rare occurrence. So how rare is childhood and adolescence MF? Let me show you some statistic over the globe. For example, in United States, according to the registry, up to 3% of the diagnosed patients are children or adolescents. This is almost the same percentage as in Europe. Whereas, please pay attention to Asia, in Singapore, for example, 1/4 of the patients are children or adolescents. Similarly, in Kuwait, 15% of the cases. And in our tiny country, in Israel, it's around 10% of our patients. So what is going on here? So we have been seeing patients with pediatric MF since 1994, and I'm on the market since 1998. So we have been collecting 50 cases until 2011, and in the last 4 or 5 years we had additional 70 cases and 50 cases as consultations. And this is a joint project between our department in Rabin Medical Center and the Schneider Children's Medical Center, which is close by. So we are a referral center not only from Tel-Aviv area, but actually from all over Israel. So what do we overdiagnose the mycosis fungoides in children, or is it really more prevalent in our country? Well, I looked in the literature, and specifically for your audience, that you are American, what's going on in America? So in America, for example, in UCSF, 4% of 500 patients reported onset of their MF by history before the age of 20. Namely, the patient comes to the doctor and said, I have it for a long time. But just 2%, namely half of them, diagnosed before the age of 20. Similarly, in MD Anderson, 5% of the 1900s patients reported juvenile onset. However, only half of them were diagnosed before the age of 20. What does it mean? For me, it means that mycosis fungoides is underdiagnosed in the pediatric age group. And why? Because there is low index of suspicion. Who will think about mycosis fungoides in a child? Secondly, there is often a reluctance to perform biopsy in children. We all know it's not pleasant, specifically to young patients. And clinical presentation in many cases are unusual and sometimes simulate other inflammation like atopic dermatitis, like psoriasis, like insect bites. Why to think about mycosis fungoides? But I think the awareness of the disease increased in the recent years, as evidenced by the increase in the number of the publications over the years. You see that from 1990 till 2008, it was a plateau. And thereafter, there is a big rise in the reports, in the literature, which reflects, I think, the increase in the awareness of our patients, as well as of the medical community, to this pediatric MF. So, just to give you some background about the mycosis fungoides in children, this is the most common lymphoma, cutaneous lymphoma in children, and this is similar to adults. You know that the most common cutaneous lymphoma in adults is mycosis fungoides. The mean age of diagnosis is during adolescence, around 14 years. But there are patients that are being diagnosed even as early age as 1 year. I have a patient that is 1 year, and we diagnose it as unequivocal case of mycosis fungoides. And as in adults, also in children, there is a lag period between the onset of the eruption and the diagnosis, and you can understand why. What is very encouraging is that the vast majority of the cases are early stage disease. And it's very extreme to diagnose advanced stage disease among our pediatric population. A second thing, that the course is very indolent in the pediatric age group. And in contrast to adults, in which, according to several reports, early stage MF can progress to advanced stage disease, in children is very, very rare. However, long-term prognosis is still unclear. We know, for example, in our group, that we have a mean duration of follow-up is 6 years. So I can tell you that the mean during this follow-up period, the course is very indolent, but I can't tell you for sure what will be in 20 years from now. But generally speaking, it's a very indolent disease. And for example, in our group of 84 cases now diagnosed in our department, only 3 cases progress, and only 1 of them progress from early to advanced stage disease. So it's very encouraging. What about the clinical manifestation of the disease? As opposed to adults, that in most of the cases, it's the classical presentation of MF, namely patches and plaque on the unexposed area, namely breast, lower abdomen, buttocks. And in children, this presentation is quite rare, as you see, just 6 of our 50 cases presented this classical manifestation. However, most of the cases present with unusual manifestation, and this misleading manifestation, of course, causes the delay in the diagnosis. For example, in our series, 45% presented with not erythematous, reddish, classical lesions, but whitish lesions, like what we call hypopigmented lesions, as you see here. And as opposed to adults, that the lesions are on the unexposed areas, in children, sometimes, as you see here, is in the exposed areas of the body. So overall, we know it's called hypopigmented MF. It's overrepresented in the pediatric MF, in the pediatric patients with MF, and it's more common in darker skin types, including Asians, but can affect also people with light skin. And just to show you some additional examples, it can also affect the face. And it looks like really something benign, hypopigmented disorder. And just to show you a case of 16-year-old girl that has light skin with hypopigmented lesions. And on the right, you can see an 11-year-old boy with pigmented lesions, skin with hypopigmented lesions. Now I will switch to the folliculotropic variant. You know that you know about folliculotropic MF. You heard about it? Yes. Okay. So just to tell you that in adults, it's regarded very rare occurrence. Usually, mycosis fungoides affects the very superficial area of the skin. But there is a subtype in which the lymphocytes have tendency to involve the hair follicle. And because the hair follicle is rooted deep into the skin, that's why the lesion is a little bit deeper than the usual superficial type of mycosis fungoides. And it translates also to the clinical manifestation, because you see here a child, and what you see here, a reddish patch, but on which you see many, many dots. Each dot represents the opening of the hair follicle to the superficial area. And here it's close-up view. And these are tiny hyperkeratotic scaly papules that are superimposed on these patches. And this is very, very typical to folliculotropic MF. And just to show you that here you see the epidermis, and here you see the hair follicle. And as opposed to classical MF, which involves the epidermis here and the interface between the epidermis and the dermis, in folliculotropic, it involves the hair follicles. So that's why it's deeper. You see it? Okay. And here you see many lymphocytes in the hair follicle. And because the hair follicle is involved, sometimes there is hair loss. And this hair loss is a clue to the diagnosis of folliculotropic mycosis fungoides. As you see here in this 5-year-old, you see hypopigmented patches, but they are hairless. Okay? And here another close-up view. You see hairless patch with follicular papules. You see? And these are anterior shins of an adolescent. Please note, here, this young boy has hairs, and here, no hair. This is a clue. Okay. So until recently, it was generally accepted that a person that has folliculotropic MF usually has aggressive disease and usually has multiple indurated plaque, namely thick lesions on the head and neck. But however, 2 recent publications, one of them is ours, showed that folliculotropic presents with 2 distinct patterns of clinical-pathological features, early stage and late stage, each with different prognosis. An early stage folliculotropic MF has an indolent course similar to classical early stage. And what I showed you here in our patients, all of them actually had early stage folliculotropic pediatric MF. So all of them have also indolent course as classical MF, and this is very encouraging and very important to tell the patients that although their young child has folliculotropic MF, still it's an early stage, it has indolent course, and the prognosis is actually similar to conventional mycosis fungoides. It's a very important message. Okay, what is the workup? The workup is the usual as in adult, but what about imaging workup? There are no current guidelines. As Dr. Horowitz addressed you to the NCCN guidelines. In the NCCN guidelines, they are for adults in mycosis fungoides. They are not specifically designed for the pediatric age group. And there are, as you see, in the NCCN guideline, it said that somebody has 10% and more of his body surface area covered by mycosis fungoides, he has to undergo CT or PET-CT. But for children, we try to refrain to do CT because of the hazards of the CT. So our policy, although it's not written, but our policy in our department is not to refer children with early stage MF to CT or to PET-CT. This is very important. Now, next, after I make the diagnosis of early mycosis fungoides in a child, the most important thing is, the question is how to treat him. So, when you look in the literature, the data is very scarce regarding the treatment of pediatric MF. And the general notion is that there is no difference between the approach to an adult and the approach to a child. Is it really the case? Children are not just small adults. We all know it, right? And in selecting therapy, the risk-benefit ratio is of particular importance in the pediatric age group. And the short-term benefit of any treatment should be balanced carefully against the potential for short and long-term side effects. So what are the treatment options for early mycosis fungoides in children? Topical steroid, phototherapy. In sunny areas, you can send the child to just sun exposure. Topical nitrogen mustard, which if I have time, I will say 2 words, or wait and see. What about topical steroids? We all know that it's very popular to apply potent or even super potent topical steroid on localized area in adults. But in children, we do it. However, long-term use of topical steroids should be avoided in children because pediatric patients have several unique characteristics that can cause higher systemic levels of topical glucocorticosteroid. So we do use it, but we have to limit the time. What about phototherapy? Phototherapy usually is the first-line treatment for older children. But it's not suitable, of course, to very young children, 4 years, 3 years. They can't get into the cabinet and get the phototherapy. And please note that we don't have any information about long-term safety in children, as we know in adults. Therefore, we give a course of phototherapy to children, but we avoid usually from maintenance treatment. You all know that once you get narrowband UV or PUVA, you reach clearance, and then the doctor sometimes offer you to start reducing the frequency to twice a week, once every 2 weeks. Usually, we don't offer it to pediatric patients, usually. Okay, narrowband UVB is regarded as very safe among children. We give it also to children with psoriasis, so it's quite safe. And recently, guidelines for phototherapy for mycosis fungoides Sézary syndrome, a consensus statement of United States Cutaneous Lymphoma Consortium was published, and it's written here that for pediatric patient, UVB and PUVA is relatively safe, although it's written caution. But sometimes we do give PUVA. You know, PUVA is psoralen plus UVA. You all know it. But usually we refrain from giving it to our kids because it's less safe than narrowband UVB, and it's not comfortable for a child to wear the glass, to avoid from sun exposure. It's very difficult for the child. So when do we offer PUVA? We offer only for patients who have thick plaque. Thanks God, it's very rare among children, but we also offer it to folliculotropic MF, which, as I showed you in our case series, it affects almost 40% of our cases of pediatric MF, which is very often diagnosed in our young children. So we do offer them PUVA. Why PUVA and not narrowband? Because as I showed you, the lymphocytes are deep around the hair follicle. So for the narrowband UVB, which is the more superficial irradiation, it's hard to get so deep. And PUVA usually gets deeper into the skin. So that's why it's more recommended to give PUVA to folliculotropic MF in adults as well as in pediatric patients. And also sometimes we give PUVA to those rare cases who fail to respond to narrowband UVB. In Israel and in Europe, we can offer an alternative, which usually it's not, I know, available in the States. It's Puva bath. Instead of giving the oral pills of the Sorlin, we put the Sorlin in a bath, and then the child gets inside. He baths himself for 20 minutes, then he washes himself, and then he exposed to the UV. By this, we avoid the systemic absorption of the Sorlin, and we avoid all the side effects, including the necessity to avoid from sun exposure. So it's quite a good option for folliculotropic MF in children. Okay. What about topical nitrogen mustard, Valchlor? We also have Valchlor in Israel since this January. There is limited experience in children. It's not licensed for children, but there is some limited experience. In our institution, we used to do the compound product in only 4 of our cases. In cases that didn't respond or couldn't get the Puva, and there are some safety and tolerance problems. And for example, Dr. Duvik, in her publication 2 years ago, wrote that because of the common adverse effect of contact dermatitis and the potential for carcinogenic effect, topical nitrogen mustard is not recommended as first-line treatment for pediatric patients. I agree, but sometimes it's inevitable. And the last option in a patient who has folliculotropic MF that is not a candidate, as I told you, for narrowband UVB and cannot get Puva, we can give him the combination of UVA and UVB as we give, for example, to patients with atopic dermatitis. So this is our experience. I will conclude. So in summary, regarding management, the management of pediatric MF is challenging. There are still many unanswered questions, and there is a need for a consensus regarding the recommended therapeutic algorithm for pediatric MF. And by this, I thank you very much.
Thank you, Dr. Hodak. So I think we have a couple of minutes for questions.
The question is, how do you recommend treatment of hypopigmentation, and how long does it take for the skin to regain color?
Okay. Hypopigmented MF responds quite good to narrowband UVB. So the first-line treatment usually is narrowband UVB, and it takes around 30 exposures usually to achieve almost complete response or complete response. And in parallel to the clearing of the lesions, there is a regression in the whitish hue, and you start to see repigmentation. Namely, there is the skin regains its original color, but it takes several months. But overall, this type of mycosis fungoides responds very well to narrowband UVB.
Okay, so questions from our audience. Yeah.
One of the earlier slides you put up was a globe, and it showed the diagnostics of juvenile MF across the globe.
Of pediatric MF.
It was significantly higher in Asia, Singapore, and very low in North America. And I just had 3 thoughts on the reason why. Was it genetic? Was it diagnostic? Was it maybe the proximity to more direct sunlight? What was the rationale for the differences?
3 of your points are very well points. So I'll tell you, I think it can be genetic, of course. Maybe there is one option that a person with a more pigmented skin, the lesions are more easily detected than in a person with light skin. Because in children, the hypopigmented lesions are very common. So I think it's easier to detect the hypopigmented lesions where the surrounding skin is more pigmented than in light skin patients. This is one option. And maybe also it's something to do with the environment, which I don't know. But I tell you, for example, in the United States, they made statistics and they found that overall, the diagnosis of mycosis fungoides, whether it's hypopigmented or the classical one, among African American, is in younger patients than in the other population. So it has to do something, I think, with genetics, not only with the color of the skin. I made myself clear? But among adults, the percentage of hypopigmented lesion is just 3% of all our cases. So I don't think it's a mixed diagnosis.
In a young adult, mid-20s or 30s, with folliculotropic mycosis fungoides, when nodules come and go without special treatment, nodules coming and going, how can you tell the difference, biopsy, between nodules coming and going or pure tumors?
Usually, lesion eruptions that consist of nodules that comes and goes, it's not the typical course of mycosis fungoides. So in the context of mycosis fungoides, if a patient has in addition such eruption, I would suspect about like lymphomatoid papulosis. Namely, additional, it's not really a lymphoma, it's a lymphoproliferative reaction that sometimes is associated with mycosis fungoides. And what you described to me now is quite characteristic, not to mycosis fungoides tumor stage, because tumors in mycosis fungoides do not tend to regress spontaneously, usually. And of course, not in a repetitive fashion, as you described to me. So it's very important in such a case to obtain, of course, a biopsy and to do the clinical pathological correlation.
With a diagnosis of follicular mycosis without hair loss, is there a difference between in treatment or diagnosis regarding when it has hair loss and when it doesn't?
No, the treatment is the same. It's just a clinical clue to suspect the diagnosis of folliculotropic MF.
So you mentioned that nitrogen mustard is generally not a recommended treatment for children because of the safety problems. Would you also not recommend nitrogen mustard as a treatment for someone in their 20s because of the same safety problems? No.
The pivotal study that on the basis on which FDA approved nitrogen mustard was on individuals above the age of 18. So a person in his 20s qualified for nitrogen mustard.
Okay. Okay, we'll take one more question. Jack, hang on just a second. I'm going to try to...
I just wanted to find out if when you diagnose an 18-year-old with MF, have you seen that they had a history of atopic dermatitis or a skin condition like since birth or 10 years of age, or because like I had skin conditions forever since I was 10 years old, and I went to NYU, I went to all these places, and I went out to Arizona even, and I've always had very bad skin, and now I have Sézary. 4 years ago was diagnosed as Sézary. But the skin fell really off. But I was wondering if a child could have it throughout. Atopic dermatitis will be diagnosed as typical dermatitis, and then transform into MF or, a cutaneous lymphoma.
Okay. Atopic dermatitis affects 1/4 of the children, so it's a very common disease. Mycosis fungoides is a very rare occurrence. According to our experience and the world experience, there is no increased incidence or prevalence or occurrence of atopic dermatitis among MF patients, also among pediatric MF patients. But it's true that sometimes first of all, can be coexistent. It's not inevitable because atopic dermatitis is a very common disease. So a person can have a common disease and a very rare disease. But there is another alternative that this child who was diagnosed as having atopic dermatitis, maybe from the beginning it wasn't an authentic atopic dermatitis, but it was a mycosis fungoides simulating atopic dermatitis. And sometimes I see young patients who were diagnosed as having atopic dermatitis, and one of the hallmark symptoms of atopic dermatitis is itch, and they didn't have any itch. So I wouldn't call them from the beginning atopic dermatitis. And the take-home message for pediatric children as well as to adults, if you have very unusual atopic dermatitis, you have to think about another option, and you have the doctor should recommend to you to undergo biopsy. And it also holds true for unusual psoriasis. So this unusual chronic so-called benign inflammation can just be the very early beginning of mycosis fungoides.